Thank you. Charles Miller with Texas 2036. Appreciate your time here and listening to us today. Thank you, community members. Texas 2036 approaches the affordability in healthcare with a recognition that the market really hasn't been functioning well. And we look at this from what are the required elements of a functioning healthy market. And we see that healthy markets are informed, they're competitive, and they're engaged. Informed directly relates to that needs to have information on price and quality out there. And there's been a lot of work by the state recently and the federal government to increase price transparency. So on this first step, we're actually doing pretty well. There have been hospital price transparency requirements. There have been insurer price transparency requirements. And as Lee talked about, there has been the establishment of the APCD. I would second the call for funding. And for those who are looking for an additional reason why the state might be interested in funding the APCD, all of the state benefit plan claims are in there, and outside researchers could create innovative solutions for bringing those state costs down at no cost to y'all if you fund the APCD and make that research available to them. So just a little plug there for that. Also, on the hospital price transparency requirements, Texas 2036 just recently released an update. We have been tracking compliance with those for the last several years once they have gone into effect. We are looking at whether or not those machine-readable files are there, whether or not they are useful, whether they can be downloaded, and whether or not they include the actual negotiated prices. Our most recent evaluation, which we released yesterday or maybe the day before, shows that 81% of hospitals in Texas are now receiving our highest grade. Now, this is a substantial increase from when we started several years ago when compliance was down around 33%. We're receiving that highest grade. So we're making a lot of progress there in terms of what prices are out there and what prices are available. But the real question is, what do we do with that information? And as one of your House colleagues is fond of saying, if all you have is transparency without more, you just know how badly you're getting, I think he says, is hosed. And so what you need are the next steps of that marketplace, and you need them to be competitive, so you need to have choices, and you need a market that is engaged, which means that we have the right incentives in place. So what does that mean, really? What are we going to do when we have this price transparency information? Well, we see that there is a wide extent of price variation. And so that means that for the same service in a same area, prices can vary by a factor of up to 10 to 1. And we heard about some of these price differences earlier, where a surgery might cost $6,700 or it might cost $46,000. Well, once you have access to what those prices are, you would tend to be driving people and incentivizing people to go to the one that is providing the better value. That doesn't always necessarily mean the absolute lowest cost, but when we're seeing a price variation of 10x, there's plenty of room to find high-value, high-quality providers who are offering care at a lower cost. So this gets into the discussion of what can we do about this. Smart employers and insurers would want to design benefit plans that include incentives for their patients or enrollees to go get high-quality, low-cost care. And two of the most common methods for doing this are known as steering and tiering. Steering would be offering incentives for your patient to go to a high-quality care. A common example is if you know that there is a low-cost, high-quality hospital for childbirth in the area, you could offer your patients free diapers for a year to go there. So that is an incentive for them to choose a particular provider and steer those patients to that. There are other strategies known as tiering, and so you can offer tiered networks so that providers who offer the best combination of value are in the most preferred tier, and providers who offer a lesser combination of value are in a less preferred tier. And those tierings impact things like cost sharing. So you might have a different deductible, you might have a different copay to incentivize them, again, to go get care at that higher value level provider. The legislature last session passed a groundbreaking law, House Bill 711, that was designed to enable these strategies to operate more effectively. Now, steering and tiering are not without their risks. One of the risks that we face in a steering or tiering strategy is the risk of self-dealing. And this can occur if an insurer has a wholly owned or controlled provider group, or if a health system, like a hospital system, actually runs a health benefit plan. There is the risk that they would want to steer or send patients to their wholly owned or affiliated group, even if that's not necessarily in the best interest of the patient. What House Bill 711 included was a really interesting protection there and said, when a health benefit plan is going to utilize one of these strategies, it has a fiduciary duty, which is the highest duty that the law can impose, to do so only in the best interest of the patient or policyholder. And so that is a really strong protection, but also really flexible protection against the risk of potential self-dealing. We think that this is a strategy that could be applied in a number of different ways that allows for the power, the beneficial parts of steering and tiering to take advantage of this price variation that we see, while also protecting against the risk of the negative aspects or the potential negative aspects of that. And so we would encourage you to consider expanding that use of fiduciary duty to other types. In House Bill 711, it only applies to health benefit plans. It does not apply to PBMs. That may be a consideration for how to apply that in that context to address some of the things that were being discussed here with inappropriate or steering or tiering that is not in the patient's best interest. One of the things that I wanted to talk about also was the implementation of House Bill 711's fiduciary duty standard and things that came out. So while House Bill 711 did prohibit anti-competitive contracting terms that would have prevented employers and insurers from doing this, it did not directly address other potential state law barriers to our state-regulated insurers from doing the same. While we think that the fiduciary duty standard is a good protection there were other potential barriers in place. During the rulemaking process, there was some back and forth with the Department of Insurance, and one of the things that came up was, well, what are the other potential statutory barriers that would prevent a state-regulated insurance plan from offering a tiered benefit plan or a steering reward scenario? And at first, it seemed as though there may have been some freedom of choice discussion. The department appeared to clear off and say that the freedom of choice provisions no longer would prohibit a steering or tiering in this scenario. What they did say, though, was that there's a provision code in Chapter 1460 of the Insurance Code related to ranking physicians. This is a provision of the insurance code that basically says if an insurance plan is going to rank physicians in any way, it has to go through a set of procedures to do so. And I would say, looking at that these procedures are outdated a little bit and also maybe overly burdensome. These could stand to be updated. For example, if an insurer is going to use quality assessments or quality rankings, they are directed to use them from a nationally accredited institution. The two that are listed in the statute and regulation don't even exist anymore. And so this shows that this statutory provision may be in need of an update and looking at different ways of modifying this to make it so that insurers are able to provide their patients with relevant quality information of providers, but again, imposing that fiduciary duty to make so that when they do it, they are doing it in the best interest of patients. Lastly, wanted to talk about maybe how the provisions, the banning of those anti-competitive contracts are being received, and this is anecdotal. We don't have hard data on this, but when we have gone around and talked to employers and insurers who are trying to implement these, what we have heard are a couple of things. One, some insurers still haven't gotten the news. They say that when they are asked by employers, well, what about a steered benefit plan or a tiered benefit plan? They say, well, our providers or our contracts with our providers don't allow us to do that. And that indicates that maybe the word hasn't gotten out yet that those sorts of contractual provisions are illegal. Other things that we are hearing is, even though these contractual provisions are no longer allowed to be in there as a contract, that the providers are no longer able to have in their contract that you cannot have a tiered benefit plan, for example, they're still taking that as a negotiating stance. And because of the market leverage that a number of these large health systems have, even if it doesn't show up in contract, it is still taking effect through that behavior. And one potential solution to look at that would be maybe making what constitutes anti-competitive behavior from an antitrust standpoint more clear in statute in that area. With that, I'll conclude my testimony. Happy to answer any questions, as always.